ladies and gentlemen, and welcome back to ADHER-ENT First and 15. Our guest today is Professor Sarah Wise, which is the Professor of Otorhinolaryngology and Head and Neck Surgery from Emory University of Atlanta. Good morning, Sarah.
Good morning. Thank you.
Thank you, too, for attending our ground rounds. So today I'm briefly introducing the topic of Sarah, which is the interesting paper published years ago about the International Consensus Statement of Allergy and Rhinology. And she's going to talk about allergic rhinitis and highlights about that topic today. So I'm leaving the torch to her. And please do remind that all the questions should be asked at the end of the meeting. And please go ahead with your presentation.
Thank you so much, Puya. It's my absolute honor and pleasure to have been invited to participate in this session. And as you all heard, I'm going to discuss largely a document that we published in 2018 called the International Consensus Statement on Allergy and Rhinology, Allergic Rhinitis. This is a large document, so today we'll really just be hitting some highlights. And I'll talk a bit about the methods that we use to put this document together, some of the interesting findings, and some of the areas for further investigation and research in the future. I am from Emory University in Atlanta, Georgia, so hello from the US. It's wonderful to be on this session, and I appreciate everyone tuning in. These are my financial disclosures. I don't believe any of these are particularly relevant to what I'm discussing today. And as I said, we're going to talk a bit about some of the methods behind this document, as well as some of its recommendations and where we might look in the future. So, what is the current state of evidence in allergic rhinitis? I think this is something that we all frequently ask ourselves as we look to provide the best treatment for our patients with this disease process. It's important that we understand the evidence in allergic rhinitis so that we can have a foundation on which to build the individual treatment recommendations for our patients. This is the citation from our document, the International Consensus Statement on Allergy and Rhinology, Allergic Rhinitis. And as you can see from the primary author list, it's a conglomeration of several nations, several different specialties, really an international effort put forth for this document. One thing that I will highlight is that the document, the primary document, is very long. It is intended to be a reference document, and I'll talk a little bit about some of the features that we included to help make this easier to use as a reference document. I've included at the bottom of this slide a link that can be used for a free download of the document there that you can see. So ICAR, as we call it, ICAR, allergic rhinitis, took us about 18 months to prepare. It's nearly 250 pages and involved over 100 authors, 72 primary authors, you saw the list on the previous slide, as well as 35 additional consultant or junior authors. And as I mentioned, this was an effort of otolaryngologists, allergists and immunologists. We had contributions from pediatricians, pulmonologists, rhinologists, folks in environmental health, nursing, and various others. We included 8 broad content areas, which I'll outline in just a moment, and a total of 103 individual topics related to allergic rhinitis. If you download the PDF version from the electronic link that I'm providing, and you look at the table of contents, you're actually able to jump to each individual topic related to allergic rhinitis so that you really truly can use this as a reference. Identify the topic in the table of contents and go straight to that topic through an electronic link. So really you can use this kind of on the fly in your practice if you have any questions related to a specific area. We also have an executive summary that was put together by the 3 primary editors of the document, myself, Sandra Lynn, and Elena Toscala. And this is a summary that basically goes through the purpose of the document, methods, its primary content, and recommendations. And I'd like to say an extraordinary thank you to Sandra, Elena, and all of the authors that were involved in this effort. We really could not have done it without the input from everyone. So the 8 broad content areas or sections that I mentioned before include the definition and differential diagnosis of allergic rhinitis, its pathophysiology and mechanisms, epidemiology and risk factors, really what the disease burden is, and that includes things like socioeconomics, effect on sleep and quality of life. We address methods for evaluating and diagnosing allergic rhinitis, as well as managing the condition through things like environmental controls or allergen avoidance, pharmacotherapy, some alternative therapies, and of course, immunotherapy methods as well. And then finally, we address some associated conditions, things like rhinosinusitis, nasal polyps, allergic conjunctivitis, cough, laryngeal manifestations, otologic manifestations, things like that. So really, what is this document? I would say it's a critical summary of the existing evidence related to allergic rhinitis. It really is a systematic review, but it's not a meta-analysis because the data was not reanalyzed. It is intended to be a resource for evidence-based recommendations. And each of these recommendations, as we'll see, considers not only the effectiveness of that particular diagnostic modality or therapy, but it also considers the benefits, the harms, and the cost of each intervention in making the individual recommendations. And then finally, what I think is one of the most important things is that it's not important enough for us to just know what we know. We have to know what we don't know, right? Or we have to think about what we don't know so that we know where we can research in the future, where our knowledge gaps are, and where we can direct our investigations in order to understand this disease process better. So the methods that we use are based on the evidence-based review with recommendations process that was developed by Luke Rudnick and Tim Smith. And for anyone who's familiar with the International Forum of Allergy and Rhinology Journal, this is something that we see appearing with some frequency. This method has become fairly popular in analysis of the literature, and there are several publications within the IFAR journal that use this methodology. So basically what this involves is reviewing the literature and looking specifically for high quality evidence. All of the evidence is assessed, but the high quality evidence is kind of given a little bit more, I guess it's considered more highly in evaluating the possibility of recommendations. So things like systematic reviews, meta-analysis, clinical practice guidelines, high quality randomized controlled trials, etc. So once the evidence is gathered, it is summarized and put together in a structured literature table that we'll look at here in a moment. Based on all of that evidence and the level of evidence, an aggregate grade of evidence is assigned, and then a recommendation comes from that, again, considering benefit, harm, and cost. And then once that's developed by an initial author, it undergoes subsequent iterative reviews by additional authors in a blinded fashion so that those additional authors can ensure that what is being presented is appropriate based on what the status of the evidence is. Eventually, a final consensus is reached amongst all of the authors, and then the manuscript goes to publication. So this is an example of an evidence summary table that's included in evidence-based reviews with recommendations. And you can see here that this very, very succinctly describes the studies that are included, the level of evidence, the study groups, exactly what was looked at in the study, and then eventually the endpoint and conclusion. And that's included for each study that's evaluated. And then based on all of those studies together, an aggregate grade of evidence is determined. And so you can see that the aggregate grade of evidence is going to be highest for things like well-designed randomized controlled trials. And then things like observational studies, expert opinion, case reports are going to fall lower. With that aggregate grade of evidence, as well as considering the benefit and harm of that particular diagnostic modality or intervention, ultimately a recommendation is developed. And depending on the balance of benefit and harm, as well as the evidence quality, the recommendation will come down somewhere between a strong recommendation for or against that intervention. You can have things like recommendation, option, or even no recommendation if there's not enough evidence on which to base that. The final step is to summarize the literature in this manner. So the aggregate grade of evidence and the number of studies that those are based on is listed. A summary of the benefit, harm, and cost, and then kind of a balance assessment between the benefit and harm. And ultimately the policy level. So the policy level is the recommendation. And then listing what the actual intervention is. So some existing evidence-based reviews with recommendations are listed here. These are just a few. There are many, many more out there. And then, as I said, that evidence-based review with recommendations process was actually used for each individual topic within the ICAR documents. The first ICAR document that came out was the rhinosinusitis document. Many of you may be familiar with this. This was led by Richard Orlandi, and it was an incredible effort. And then several additional ICARs have come out or are in the works. So our allergic rhinitis document was second. And then just this summer, the skull base ICAR came out. There are additional ones in the works, such as for sleep, nasal obstruction, and then we're coming up on the fifth or sixth anniversary of the rhinosinusitis document soon, and so there will be an update of that one coming out in a couple of years. So as I said, the ICAR documents are really a summary of the existing evidence and then recommendations that come from those. We have to take those recommendations as kind of our foundation on which we build our treatment for our individual patients. We still need to treat our patients as individuals. We need to use our clinical acumen as physicians to determine the best treatment for them, but we should really be familiar with what the evidence says for these processes. So again, from the ICAR process, we learned what the current state of allergic rhinitis evidence is. We learned what we know. We learned what we don't know. As I said, that's really important as well. We also, in learning what we don't know, we're able to kind of put together what the knowledge gaps and areas for future research are, and I'll discuss a few of those later. But first, let's talk a little bit about what the current evidence for allergic rhinitis is in some of our treatment modalities. So things like antihistamines. I think we're all pretty familiar with the fact that histamine is a major mediator in allergic rhinitis, and so antihistamines have been used for many, many years to treat allergic rhinitis, and other allergic manifestations. So the evidence for the use of antihistamine rhinitis is incredibly strong. For oral antihistamines, there have actually, at the time of publication of this document, there were 21 studies that were actually meta-analyses that looked at oral antihistamines. They tend to be relatively low cost. In the US, the vast majority of these, not only the original first generation antihistamines, but also the second generation non-sedating antihistamines, are the vast majority are available over the counter without a prescription. The benefits outweigh the harm, especially for the second generation non-sedating antihistamines, and ultimately these had a strong recommendation for their use in allergic rhinitis. The oral antihistamines tend to be a favorite of patients because they generally prefer to use a pill rather than a nasal spray. They are also very beneficial for patients that may have other allergic manifestations, skin manifestations, for example. The intranasal antihistamines, at the time we put this document together, had very strong evidence in the form of randomized controlled trials. They tend to be low to moderate cost. For us in the US, they are prescription, but they work great for things like sneezing, itching, rhinorrhea, ocular symptoms. The downside of the intranasal antihistamines is they do tend to have a little bit of a foul taste, which some patients have some difficulty tolerating, but they are a great medication to use and recommended for allergic rhinitis. Intranasal corticosteroids have been a mainstay of treatment for allergic rhinitis for many years as well. In the US, they are relatively recently over the counter, but they are well supported by evidence, 15 meta-analyses, and then additional study, randomized controlled trials as well. Very strong benefit for seasonal allergic rhinitis, benefit for perennial allergic rhinitis as well, and these obtained a strong recommendation. They really tend to be a first-line therapy for allergic rhinitis. Other therapies that have very strong evidence, all level A evidence, include nasal saline in various forms, intranasal corticosteroid plus an intranasal antihistamine combination. This, for us, tends to be a little bit of a second-line treatment if patients do not tolerate, or if their symptoms are not fully controlled by an intranasal corticosteroid alone. We tend to use the combination. It does tend to be a bit more expensive, but it actually has great, the synergy of the two medications together tends to be great for allergic rhinitis. And then certainly subcutaneous immunotherapy has a long history of benefit. Sublingual immunotherapy clearly has been in use in Europe and very well studied for many years. We're a little bit behind in the US with adopting sublingual immunotherapy, but in the last 15, 20 years, it has really taken off. We have sublingual tablets available here since 2014, and then also aqueous drops used off-label as well. So the studies for subcutaneous and sublingual immunotherapy in allergic rhinitis generally tend to be single antigen studies, usually not multi-antigen mixes, but they do show excellent benefit. And there is some variability depending on the antigen, depending on the patient age, et cetera. So I would encourage you all to really look through the document to look at the specifics of those things. But I think we can say in general, subcutaneous and sublingual immunotherapy have been great therapies for the treatment of allergic rhinitis, and are really as far as immunotherapy goes, in comparison to things like pharmacologic treatment or allergen avoidance, they're really the only therapies that can affect a more long-standing, potentially permanent change in the immune system, allowing allergen tolerance in the long term. So definitely of benefit for our patients. We do have to think about things like anaphylaxis with these therapies or other systemic reactions, but that tends to be relatively low incidence. And both subcutaneous and sublingual immunotherapies are considered very safe therapies in the properly chosen patient. So what about some of the therapies that tend to have a little bit weaker evidence? We talked a bit about some of the pharmacotherapy treatments, and I've touched on just a few, especially those with strong evidence. We address many, many others in the document, things like leukotriene receptor antagonists, chromalin therapies, etc. We've talked about allergen immunotherapy, and given the amount of data that's out there for allergen immunotherapy, I've really just brushed the surface with my comments here. What we haven't talked about yet in kind of the triangle of allergic rhinitis treatment is environmental controls or allergen avoidance. So where does the evidence stand on that? It is a bit weaker than many of the pharmacotherapy and immunotherapy treatments. And I think that there are a couple of reasons for this. And this is something to really to pay attention to, because our patients are often very interested in, for example, dust mite covers or HEPA filters and how they can avoid allergens in their home, or how they can control their environment. One of the problems with a lot of these studies is that they look at allergen levels in a lot of them. So they'll look at the allergen levels prior to institution of the environmental control level measure, and then they'll look at allergen levels post institution of the environmental control level. But a lot of the studies don't really address respiratory symptoms, especially in the allergic rhinitis literature. And I think that that's really what our patients are interested in, right? We're trying to make them feel better. We're trying to make their nose less stuffy, less rhinorrhea, less itching. The patients themselves probably are not as interested in the actual antigen level. So we need to think a bit about that in future studies, really addressing the respiratory symptoms in our study of environmental control measures. We do know from a meta-analysis that was done in house dust mites that using a combination of therapies tends to be better than using a single therapy alone. So that there is some evidence to support that. These interventions can cost at various levels, depending on the specific intervention and also how many things are put into place at one time. But these are considered an option. So I think one of the things that tends to be most exciting for us as practitioners and our patients are discussions of what's new, what's exciting, what's coming out next. What are people talking about at the cocktail parties in relation to allergic rhinitis? And I think that, that sounds a little bit facetious, but certainly people do talk about their allergies, especially during allergy season. And so I think we as practitioners need to be aware of what our patients are interested in. What is the hot topic in medicine, or potentially some of the alternative therapies that they're talking about. And it's important that we know what the evidence is surrounding this. So some exciting, potentially recent developments in allergic rhinitis, some things that we may need to investigate more, but we may be hearing more about in the future. So one of those things that I'll mention is intralymphatic immunotherapy. So this is basically allergen injected directly into the lymph nodes, specifically the inguinal lymph nodes under ultrasound guidance. And the typical protocol for this is 3 injections total, each separated by about 4 weeks. And so, as you can imagine, this is reduced time in comparison to our standard immunotherapy protocols, things like subcutaneous immunotherapy, which start with weekly injections and then progress to monthly injections and involve 3 to 5 years of treatment. Sublingual immunotherapy, although it can be dosed at home, it's also several years of treatment. This specific treatment, intralymphatic immunotherapy, involves less allergen injected and tends to have lower risk of adverse events. So there have been several randomized controlled trials. Most of them are relatively small, but there tends to be some benefit seen. So this is something that we may be hearing more about in the future. Actually, I feel like we very likely will be hearing more about in the future. And I think it'll be interesting to see where this goes. I think we do need some larger studies, specifically randomized controlled trials, more subjects enrolled. I think it's also going to be important to specifically assess the safety and efficacy of intralymphatic immunotherapy compared to other more commonly practiced forms of immunotherapy, such as subcutaneous and sublingual immunotherapy. And then certainly in an era of rising healthcare costs, it's important to look at economic comparisons as well. What about local allergic rhinitis and nasal-specific IgE? So local allergic rhinitis, I think, is something that most of us are aware of at this point. This is specifically nasal symptoms, and it does involve allergen-specific IgE-mediated inflammation in the nasal cavity. The symptoms are classic allergic rhinitis type symptoms, but when patients undergo allergy testing in the skin testing or systemic methods that are typically used, hypersensitivity or positive reactions are not detected. And so this typically involves doing a nasal provocation test or actually detecting the specific IgE from nasal brushings or nasal washings, a positive basophil activation test, and again, there's no systemic reactivity that is seen. So I think this is going to be something that we're, again, probably going to see even more about in the future. There have been some excellent studies done in Spain by one of our authors on the ICAR document, as well as some immunotherapy interventions for patients with local allergic rhinitis. But certainly here in the US, we don't really have a commercially available easy way to do this. It's typically done in kind of research protocols. We don't really have a lot of normative data. How do the levels of specific IgE in the nasal mucosa compare to those that we potentially see systemically? And so this, I'm hopeful that we'll see even more about this in the future and be able to offer this to our patients. What are the things that we as clinicians and practitioners may not talk about much, but perhaps we should? What topics are important to our patients? Again, what are the cocktail party conversations potentially that we could better address? What about things like acupuncture or some of the alternative therapies for allergic rhinitis? And I'm just mentioning acupuncture here, but there are others that have been studied. Things like the use of honey, etc. So acupuncture has been studied in the treatment of allergic rhinitis. There have actually been several randomized controlled trials of actual acupuncture versus sham acupuncture. There have been 2 meta-analyses that have looked at the results of these studies. The initial one in 2008 included 7 studies, and at that time did not identify a benefit for acupuncture in allergic rhinitis. But in 2015, there were actually 13 studies included in this meta-analysis, and they did note a significant reduction in nasal symptoms, improvement of quality of life questionnaires, and reduction in the use of rescue medications. So this may be something that your patients may ask about. What about probiotics? So this is also something that I think we hear about in the rhinosinusitis realm, potentially in the allergic rhinitis realm. There's, certainly a lot more interest in the microbiome research lately. There's a huge probiotic market in the US, nearly $3.3 billion in 2015. So people are definitely interested in this, and there have actually been some studies looking at this. Ultimately, when we reviewed this as part of our document, it was found to be an option. And that was largely because when we say probiotics, that's a really large encompassing term. There are lots of different individual products that are marketed as probiotics. And so there haven't really been enough studies of individual products so that we could say, a specific product is beneficial. So I think more research needs to be done in this realm as well, and I'm excited to see where this goes. So finally, I'm just going to mention some of the things that we might need to work on in the future, our knowledge gaps. And this is certainly something that we'll be looking for people to publish in this area. These are things that I will certainly be interested to see if we've had additional evidence show up by the time we potentially do an ICAR allergic rhinitis update in a few years. I think we need to understand a bit more about the genetics of allergic rhinitis. We know that allergic rhinitis runs in families, so we definitely need to understand a bit more about the genetics and potentially environmental interaction. And that leads me to my second comment, things like climate change. Climate change is happening, and we know that allergens are affected by the climate. So where will climate change take us in the future with respect to the prevalence of allergic rhinitis, patterns geographically, et cetera? We certainly could learn more about the diagnosis of allergic rhinitis. I mentioned nasal-specific IgE, basophil activation test, which is an ex vivo laboratory test that it has had some research behind it looking at allergic rhinitis, as well as really our skin testing techniques. There's a lot of debate around the role of an intradermal test following a negative prick test in skin testing techniques. Treatment of allergic rhinitis, I've mentioned several treatments today. In fact, that was really the thrust of this entire talk was focused on treatments. We need to better understand economic comparisons of immunotherapy modalities, sublingual versus subcutaneous immunotherapy, each of those potentially versus intralymphatic, if intralymphatic does turn out to be a useful method of immunotherapy widely in the future. And there are many, many others. We addressed several knowledge gaps in the document, and I would encourage you to take a look at those, especially if you are a young researcher with an interest in this field. I would love to see people publishing in this and include some of your work in future updates of the document. So I think it's important, as I've mentioned, that we understand the evidence that exists for the conditions that we're treating and use those as our foundation to treat on which to build individualized patient management. We have not in this document dictated what you absolutely should or should not do. We have given recommendations based on the evidence, but again, we are practitioners and clinicians, and we should use our knowledge and our experience to individualize patient management. So thank you again, Puya. I'm very, very honored to be here, and I hope that I've provided some useful information for everyone.
Thank you, Sarah, for your brilliant presentation, which summarized the document that you presented, and I'm encouraging to the colleagues to download this document if they didn't. I just want to point out two things. The first one, when you were talking about the tests for the non-allergic, I mean the nasal allergen, we had a topic which was discussed from the past president of the EAACI juniors, you might know,
Yes.
Yvonne Aguiluz, who was talking exactly about the nasal allergen challenge, the methodology, and the clinical usefulness recently in June. And we discussed about this thing, and I'm glad that you also point out once again the importance of these tests and the importance of these diseases which are struggling those patients when they are not figuring out anything on systemic tests. So thank you again for this. And the second thing is that we also had one of our ground rounds with Joanna Gaki, which she were talking about the endotype driven approach for the precision medicine, and she was actually comparing the asthma and the allergic rhinitis. And because of that, I would like to start with the questions, which the first one is coming from Portugal, and they are asking, so because of those all these documents, do you think that the ARIA document is still valid?
I do. I think, I think we have to realize that evidence progresses, right? And we need to really look at what's coming out in new evidence. But it is important. I think the ARIA document is incredibly important because it definitely has a focus on asthma as well. We addressed asthma relatively briefly in this document as an associated condition. But I definitely use the ARIA document as a reference. And yeah, I mean, I think it is helpful.
Can you hear me back? Yeah.
Yes, I lost your volume for just 1 minute, but I can hear you.
I'm sorry. The second question is coming from Mexico, and the colleagues is asking, what's your opinion about allergic rhinitis and gravidic rhinitis?
And I'm sorry? Which?
Gravidic rhinitis? He's asking, I think that's the pregnant... the
rhinitis of pregnancy?
Yes, I'm just telling you what are they typing, so don't
yes,
get
no, I mean, clearly, yes, we clearly have different terms depending on our language and culture. So I believe that the question is about what we would call in the US rhinitis of pregnancy.
Exactly.
So, I think we definitely see that many, not all, but many pregnant women do have increased nasal symptoms, especially congestion during pregnancy. And what I tend to see in my patients is that if they have a baseline nasal condition, especially one that's associated with congestion prior to pregnancy, and then they add the rhinitis of pregnancy to that, they become substantially more symptomatic. So whether it's allergic rhinitis or rhinosinusitis, especially nasal polyps, they generally, in my experience, they tend to be more symptomatic even with their baseline condition during the pregnancy. That brings up, another sort of thought about the treatment of these patients. A lot of the medications that we tend to use for allergic rhinitis, things like antihistamines, nasal steroids, etc., can be used in pregnant women. But there are some, if we look at the pregnancy safety grading that we use here in the U.S., there are some that have been graded safer for pregnant women. For example, for us, we tend to use the budesonide nasal spray rather than others, because that carries a category B or a safer category for pregnant women. So just something to keep in mind. I hope I've answered the question.
I guess in any case, I'm addressing your, if it's possible, your personal, office email for any of other questions that we cannot provide during this conference.
Certainly. Of course, yes. I would be happy for you to pass it along. Absolutely.
The other question is from Russia, and the colleagues is asking, would you suggest nasal spray or nasal douches with steroid?
With steroid?
Yes.
Yes. So, I think that depends on the disease process that we're treating, and as well as what the patient's response has been. So here in the US, we have commercially available, FDA approved nasal sprays for allergic rhinitis. When we use a steroid in a nasal wash, that's considered an off-label use, and we disclose that to the patient. I think we also know that the distribution of the actual medicine is very different when we are using a nasal spray versus a nasal rinse. With the nasal spray, the distribution tends to be mostly in the anterior nasal cavity. So that can be very helpful in allergic rhinitis. The allergens they tend to come in first contact with the anterior nasal cavity. The airflow then will arch over the inferior turbinate and kind of contact the anterior aspect of the middle turbinate and the nasal septum that is in that region, and then kind of arch posteriorly over the inferior turbinate. So if mostly experiencing inflammation related to allergic rhinitis in the anterior nasal cavity, nasal sprays can be very, very helpful. If you're treating something more that's more diffuse, or if the sinuses have already undergone sinus surgery, if the ostia are open, if you're trying to get the steroid further into the sinus cavities, then a nasal douche or an irrigation with the steroid can be very, very helpful in those situations. I also think that I've had certain patients, even in the absence of having prior sinus surgery, that have only been partially responsive to nasal sprays, and then I'll try a nasal douche and they are much happier, and their symptoms tend to be better controlled for certain patients. So a little bit of it depends on the disease process, their anatomy, what your goals are, and their response to prior therapy. And I think when you put all of that together, you can determine whether a spray or a douche is better.
And here we come with another question, which is coming from Spain. Our colleagues is asking, what is your choosing for empty nose syndrome, so in people suffering from allergic rhinitis?
Well, I can say that I don't have a large population of empty nose syndrome patients, but in general, moisture tends to be very important for that population of patients. And so I definitely recommend nasal saline in irrigation, spray, or gel form. And then, for allergic rhinitis, we know that nasal saline can be of benefit as well. You potentially could try adding in those situations. You could try adding the steroid to the irrigation as well. I can't say that I have a large population of patients with that particular combination of disease processes. So I don't know that I can reach back into a lot of experience with that. So I certainly have seen patients that have them separately, but the combination is not something that I have seen with extraordinary frequency in my practice.
We're going to talk about this topic for the empty nose syndrome in the third segment in 2020.
Great.
I'm coming to the last question due to lack of time. And these colleagues from Africa is asking, we cannot afford immunotherapy in Central Africa. So what are your suggestions?
Well, in those, so immunotherapy for people that have access to it, can certainly be an option. But, for allergic rhinitis specifically, it's not a life-threatening condition. It can be quality of life impairing, certainly. But many patients do very, very well with pharmacotherapy options. I've discussed several of them. There are some additional ones in the document as well. And then, trying our best to control the environment, although the evidence is a bit lower for that. There has been some benefit shown. So, ultimately, while allergen immunotherapy is an option in several areas of the world, it is certainly not an option everywhere. And, in my practice, it is not something that every patient is willing to undergo. It's not something I even discuss with every patient. Certainly individualize the treatment for the individual patient. I have many patients who are very well controlled on medications, nasal saline, some environmental controls if they want to do them, and do not want to do immunotherapy, or I think their disease is controlled enough that we don't even necessarily need to bring up immunotherapy as an option.
Perfect. Last thing for me is can I just ask how much are you using the combination of a nasal spray composed by steroids and antihistamine? Because in Italy, it's very the price of these spray are very high compared to other places and other states for example, Germany or United Kingdom. So are you using frequently the combination of nasal spray composed by steroids and antihistamine, or you prefer to use just steroid spray?
So, for many patients, most patients, we will start with one, either the intranasal steroid or the antihistamine, depending on what their symptoms are, pattern of exposures, and as well as the patient's desires and past experiences. And then if they're not entirely controlled, then we'll consider adding the second component. So if we start them on an intranasal steroid, then we may add the intranasal antihistamine later, or vice versa. It is the actual marketed combination spray is also very expensive in the US, and is not, for many of our patients, it is not covered by their insurance. So in those cases, I will, if I think that using both intranasal medications would be of benefit to the patient, I will prescribe them separately, and then have them, use them at the same, in the same setting, or sometimes, they'll just use the intranasal antihistamine as needed, which is, perfectly good option. And then the intranasal steroid, we try to have them use it on a more regular basis, at least for periods where they have symptoms.
So thank you for your participation, for your brilliant explanation. And I would recommend to all the colleagues to send a personal email to Sarah for asking any other question. I'm sorry for the lack of time. This is just a quick reminder for the next upcoming ground rounds, which is going to be for the 15th of November. Our guest is going to be Yanis Konstantinidis, who is going to talk about the approaches to the frontal sinus, and this is the actual president of the European Rhinologic Society. And because of that, I would like to advertise the upcoming 2020 ERS meeting, which is going to be in Thessaloniki and is planned for, and I'm going to attend that. And I think that Sarah is also attending. I actually asked her if she's going to attend, and she's going to be in a panel for that.
Yes.
So please join that. And Thessaloniki is a nice place. So if anyone would like to attend the ERS meeting, don't forget that during that meeting, our association is going to provide 2 grants. We usually provide the junior grants because of our collaboration and support from the ERS Rhinologic Society Juniors. So if anyone under 35 years of age is participating, please subscribe to the ERS, and you will get all the benefits, and you can participate to our sessions. So thank you, Sarah, once again for your participation. I hope that you will be able to join once again in 2020 for our ground rounds. Thank you, and see you for the 15th of November.
Yes, thank you. See you in Thessaloniki.
Thank you. Goodbye.